Good evening, sir.
Hmm.
And we are discussing about journal article of adrenal insufficiency, and myself, Dr. Tejasvi, and my moderator, Dr. Sarma, sir. And we discuss under the headings of introduction, etiology, pathophysiology, histology, clinical presentation, complications, evaluation, and treatment of adrenal insufficiency. Coming to introduction, the adrenal gland is made up of two parts, the cortex and the medulla. The cortex is responsible for producing hormones like glucocorticoids, mineralocorticoids, and androgens. Any destruction or dysfunction of the adrenal cortex mainly causes glucocorticoid and mineralocorticoid deficiency. The primary adrenal insufficiency is also known as autoimmune adrenalitis or Addison's disease.
Now, hold on. So, the other day we have been talking about the adrenal hyperfunction, Cushing's, where the adrenal cortex is hyperfunctioning and producing cortisol. And today we are looking at hypofunction of the adrenal cortex. So, as you know, GFR, glomerulosa, fasciculata, reticular. Glomerulosa, mineralocorticoid, fasciculata, cortisol of the glucocorticoid, reticular is the sex hormones or sex steroids. Okay, this is the functional division. Most important thing is the glomerulosa is not controlled by the HPA. Likewise, the sex steroid production is not directly controlled by the pituitary. Through the target organ, again there is a feedback loop. Whereas for the mineralocorticoid, the feedback loop is through the renin-angiotensin system. The glucocorticoids are under the influence of the ACT. So what did you learn? You learned that the adrenal three zones are controlled by three different mechanisms. Zone 1, which is zona glomerulosa, is the mineralocorticoid part, and that is controlled by the renin-angiotensin system. That is controlled by the renin-angiotensin system. Whereas the second part, which is in the middle part, which is the zona fasciculata, is the cortisol producing, glucocorticoid producing, which is directly under the influence of the ACTH, which is again under the influence of the CRH from the hypothalamus. Okay. Now, the internal part, which is the reticularis, which produces the sex steroid, is not directly involved with the pituitary, but through the target organ, it is involved through the FSH, LH, and prolactin, which are also pituitary hormones. They act on the target organ. The target organ is influenced by the sex steroid. This is the control. So you just said that the adrenal gland, primary adrenal insufficiency, is also known as autoimmune adrenalitis. Just a second.
And adrenal insufficiency can be classified into primary, secondary, and tertiary causes. Primary adrenal insufficiency occurs when there is a pathology affecting the adrenal gland itself. And secondary adrenal insufficiency results from a decreased level of ACTH released from the pituitary gland. And tertiary adrenal insufficiency results from a decreased level of corticotropin releasing hormone released from the hypothalamus.
Now, this is very important for you to know. Commonest is the secondary adrenal, not the primary, not the primary. So, primary means the gland is at fault, adrenal gland is at fault. Secondary means the pituitary is at fault and it is not giving enough stimulatory hormone or a trophic hormone, which is the ACTH. And tertiary means the hypothalamus is not secreting the releasing hormone, that is the CRH. So CRH problem is tertiary, ACTH problem secondary, and primary adrenal problem is adrenal gland itself is at, functionally not doing the job and not producing this one due to infection, due to autoimmunity, due to hemorrhage, due to metastasis. So many reasons are there. We will see all those things. So this is the division here. There is a need to distinguish between the three because the treatment is very different. The primary adrenal disorders are not that common. That also you have to understand. Okay.
And coming to etiology, primary adrenal insufficiency is characterized by decreased both cortisol and aldosterone production due to diminished gland function. It can either present acutely, so it is called as adrenal crisis, or it may be chronic, so it is called as Addison's disease. The most common cause of primary adrenal insufficiency or Addison's disease relates to the autoimmune destruction of the adrenal cortex.
Yeah. Now we are dealing the less common, that is the primary adrenal problem. In primary adrenal problem is distinguished by the presence of inability of G and F, glomerulosa and fasciculator, both are involved. That is why you have cortisol deficiency. You also have decreased mineralocorticoid or aldosterone production. Whereas we know ACTH cannot influence the glomerulosa. So if the ACTH is at fault, we only have a cortisol deficiency and not the mineralocorticoid deficiency. That is one primary distinction. Second thing is the disease primary adrenal insufficiency can be acute, can be chronic. If it is acute, it is called crisis. If it is chronic, it is called Addison's disease. The word Addison's disease is a chronic primary adrenal insufficiency resulting in decrease in the cortisol as well as aldosterone. What is the commonest cause of primary adrenal insufficiency? Autoimmune destruction of the adrenal cortex. So Addison's disease is an autoimmune disease, just like type 1 diabetes you have. It is an autoimmune disease. Rheumatoid arthritis. You have a SLE. Like that, lupus nephritis. Like that, the Addison's disease is an autoimmune destruction of the adrenal cortex. Lot of loss of function of both the mineralocorticoid and the glucocorticoid. In the acute form, it is called acute adrenal crisis. In the chronic form, it is called Addison's disease. Okay.
And other causes of primary adrenal insufficiency include adrenal hemorrhage, cancer, or infections, which is most common tuberculosis, or other infections like HIV, syphilis, and certain drugs like etomidate and antifungals like ketoconazole, fluconazole, and mitrapone, and phenytoin and rifampin increases the metabolism of cortisol, so it precipitates the adrenal insufficiency.
So what we said was, what is the fundamental? The primary adrenal insufficiency is itself rare. That to the chronic one, the Addison's disease is an immune destruction. On top of that, there could be other causes. What are they? Sudden adrenal apoplexy or hemorrhage. Due to what? Somebody is taking anticoagulant, and probably that is the reason he would have bled into the adrenal. Or there is acute meningococcal infection, and then that meningococcal infection can lead to endotoxic damage and hemorrhage into the adrenal gland, which is called Waterhouse-Friderichsen syndrome. And other causes are malignant deposits involving the adrenal cortex. So, malignancy or infections, particularly in our country, tuberculosis of the adrenal gland can be a problem. HIV is also notorious to cause adrenal infection. Other than that, what are the causes? Addison's disease or primary adrenal insufficiency can be a long question or a short note. So you have to write autoimmune adrenal destruction. Then second one will be primary adrenal insufficiency due to hemorrhage, which will be acute. Cancer, again, it will be chronic. Infections will be acute. Tuberculosis will be a chronic infection. And drugs like antifungals. Etomidate, ketoconazole, fluconazole, mitrapone, these are some of the drugs. In addition, there are certain drugs like phenytoin and rifamycin. They will increase the catabolism of the cortisol. So much so, there will be a relative adrenal deficiency. Not that the adrenal gland is secreting less, but the hormone, before it reaches the target organ, it is destroyed elsewhere by these drugs. Okay.
And secondary and tertiary causes like panhyperpituitarism and many genetic factors can cause adrenal insufficiency. And pituitary hemorrhage or infarction, like Sheehan syndrome, can cause secondary adrenal insufficiency. Other causes for secondary includes pituitary tumors, hypophyseectomy, and high dose pituitary or whole brain radiation.
Yeah. Supposing there is a pan-hypopituitary, so that means the entire anterior pituitary gland is destroyed. Then what will happen? Thyrotrophic hormone is not released, ICT is not released, all the trophic hormones reduced, and that is possible only when there are genetic causes. And that can also cause some adrenal insufficiency. Pituitary hemorrhage, which is called Sheehan's syndrome, postpartum pituitary necrosis. And I am fortunate enough to see one case of postpartum pituitary necrosis. She was admitted for PIME, had a delivery, and then suddenly presented with the hypoadrenal features and hypotension, hyponatremia, hyperkalemia, not much of mineralocorticoid, more of cortisol, hypotension and dehydration and things like that. And that lady had luckily recovered, and she had postpartum pituitary hemorrhage, which is called the Sheehan syndrome. Adrenal hemorrhage is called Waterhouse-Friderichsen syndrome. Sheehan syndrome is the postpartum pituitary necrosis. This could cause secondary level because this hemorrhage is in pituitary, so the disease will be secondary, means mineralocorticoid is not affected. Mainly the corticoid is affected. Other causes of pituitary include tumors, just like adrenal tumors, there could be pituitary tumors, or there is some other reason the hypophysectomy has been done, or they will use a brain irradiation due to some reason, and pituitary also is irradiated, or the whole brain irradiation due to some other cause. These are the causes at the level of the secondary or pituitary level.
These are the causes of primary adrenal insufficiency. In this,
I will try to enlarge and show you. Yeah.
In this, the most common in primary adrenal insufficiency is the most common. It is autoimmune destruction of the adrenal gland, that is autoimmune adrenalitis. And in women, along with adrenal insufficiency, the other associated autoimmune disorders are also present. That is polyglandular syndromes like APS1 and APS2. In APS1, along with adrenal insufficiency, the patient have features of hypoparathyroidism and mucocutaneous candidiasis and associated with lymphomas and other autoimmune disorders. In APS2, along with adrenal insufficiency, autoimmune destruction, the patients may also have other autoimmune disorders like hypo or hyperthyroidism, type 1 diabetes, and pernicious anemia, and these patients have features of premature ovarian failure. And next one, it is autoimmune adrenalitis, that is also isolated autoimmune adrenalitis. And next one, it is congenital adrenal hyperplasia, and other causes like adrenal infarction, adrenal hemorrhage, and drug-induced adrenal insufficiency. Adrenal infections, the most common is tuberculosis, HIV, and adrenal infiltrations like amyloidosis and metastasis, lymphomas, and sarcoidosis. And drug-induced like antifungals like ketoconazole, fluconazole, and etomidate and imidazopine. These are the causes of primary adrenal insufficiency.
Yeah. More or less what we have said is it is an autoimmune main one. APS1 and APS2, isolated adrenalitis can be there, or CAH is a common cause in children. If a pediatric age group person presents with adrenal insufficiency, it is congenital adrenal hyperplasia. It can be there. The other things you have already listed. Now let us go to the next slide.
And the next is the causes of secondary adrenal insufficiency. In secondary adrenal insufficiency, the most is pituitary tumors or pituitary adenoma. These are the causes, and any associated any lesions affecting the hypothalamic pituitary regions like craniopharyngioma, metastasis, and meningioma. Any pituitary irradiation or whole brain irradiation, it leads to secondary adrenal insufficiency. And also it is pituitary hemorrhage like pituitary apoplexy, The causes are traumatic injury due to major blood loss, or any after surgery, or after parturition, it leads to Sheehan's syndrome, and others like pituitary infiltration. The causes are business granulomatosis, metastasis, sarcoidosis, and tuberculosis. These are the secondary causes of adrenal insufficiency.
Secondary is pituitary level. In the pituitary level, you have tumors, you have other mass lesions, and other than cancers, you have pituitary irradiation, autoimmune hypophysitis, adrenal apoplexy or hemorrhage due to into the hemorrhage, and you have also mentioned about the postpartum Sheehan syndrome and pituitary infiltrations due to various infiltrative disorders, drug-induced, congenital isolated ACH deficiency, combined pituitary hormone deficiency. These are various other causes, but most important cause among all is use of corticosteroids.
Exogenous corticosteroids.
Exogenous corticosteroids. Just like in the case of adrenal hyperfunction, the first exclusion is the patient on steroids. That is the first. Here also, use of exogenous steroids is the fundamental cause of adrenal insufficiency. Why? When you use exogenous steroids, there will be cortisol circulating in the blood, ACTH suppressed, adrenal gland doesn't have to function because it is getting cortisol from outside, and a physician or the treating doctor does not know how to taper properly. Suddenly he withdraws steroids, adrenal gland has not taken over, ACTH is not produced, patient goes into acute adrenal crisis. That is why when you use long-term steroids, you have to always reduce in a stepwise manner. This we call tapering. I have seen doctors who are tapering after 3 days or 4 days of use. It is not required and it is foolish. 3 or 4 days or 1 week of use of steroids does not suppress the pituitary axis to that extent, and there won't be any crisis. You don't have to taper. Don't attempt to taper a less than 1 week use of steroids. It is indicated only when a prolonged use of steroids for an autoimmune disease or a skin condition like psoriasis or any other bronchial asthma or some other condition you use the steroids for a long time, then you have to take. But sometimes patients inadvertently will be taking the steroids for a long term. They come to you with the hyperfunction features like iatrogenic Cushing. Then you slowly withdraw the steroid and then make them all right. Not suddenly stop the steroid. Okay? No. Come on.
And coming to pathophysiology of adrenal insufficiency. The pathophysiology of adrenal insufficiency depends upon the separate etiology. Most forms of primary adrenal insufficiency, it may be due to autoimmune cause. That is, the patient have antibodies that attack the various enzymes, and also genetic factors that have been identified that play a role in developing primary adrenal insufficiency or autoimmune adrenalitis. That is a major histocompatibility halotypes like DR3 and DR4.
Yeah, the point here is there are some genetic connections. MHC haplotypes are also associated. That's good enough. Next.
And second adrenal insufficiency refers to the decreased ACTH stimulation of the adrenal cortex, and therefore it does not affect the aldosterone levels. Only glucocorticoids levels are affected. And other causes of secondary are traumatic brain injury and panhypopituitarism.
Yeah, the point here is secondary cause is ACTH. ACTH doesn't cause the adrenal aldosterone level problem. It only causes the glucocorticoid problem. Sometimes there is a head trauma. Traumatic brain injury can produce panhypopituitarism, and also it can involve the pituitary, and sometimes panhypopituitarism may also be there. Okay.
And coming to tertiary adrenal insufficiency, it refers to the decreased hypothalamic stimulation of the pituitary to secrete ACTH. And the most common cause is exogenous steroid administration is the most common cause of tertiary adrenal insufficiency.
Yeah.
And a patient have any surgery to correct a Cushing syndrome, they may lead to tertiary adrenal insufficiency.
That means what? You are, the CRH problem here. CRH is not properly secreted so much, so ACTH is not coming so much, so the trophic hormone is not there, and then your target organ is not able to produce this one. Exogenous steroids not only suppress the adrenal gland, They also suppress the ACTH, they also suppress CRH. The commonest cause of tertiary adrenal insufficiency, suppression of CRH, and through that suppression of ACTH and suppression of the gland is exogenous steroid. So if you suddenly withdraw the exogenous steroid, the patient is not able to get back to the normal hypothalamic pituitary axis stimulation, and he lands up in acute adrenal insufficiency. So that you should always remember exogenous steroid administration, sudden tapering should never be done, particularly on chronic usage. Sometimes we do surgical treatment for Cushing's disease that can lead to tertiary adrenal insufficiency. Histopathology you can quickly pick up. I mean, check, read and leave it, because we are not too much interested in the histopathology part.
Histopathology varies according to the pathological process involved in adrenal gland dysfunction. In autoimmune adrenalitis, there is atrophy of the adrenal gland with infiltration of lymphocytes along the fibrosis of the adrenal capsule. As adrenal insufficiency is caused by the dysfunction of the cortex, the adrenal medulla is not affected and it is spared.
That is very important. Whenever there is an adrenal insufficiency destruction, it is the cortical destruction and not the medulla. Medulla secretes the sympathetic hormone, so it is not affected. Medulla is not affected. It's only the cortical hormones are affected. From medulla, we have got adrenaline and noradrenaline. Okay.
And adrenal insufficiency due to tuberculosis results in enlargement of the adrenal glands with caseating granulomas. The adrenal medulla is usually not spared, and the gland is characterized by diffuse calcifications. In other conditions, infective conditions like AIDS, there is an infection and hemorrhage and necrotizing inflammation of the adrenal gland present.
Now, the difference between tuberculosis and other things is tuberculosis destroys medulla also, as well as the cortex. And as everywhere, tuberculosis can lead to calcification and caseating granuloma formation. Okay.
And coming to clinical presentation, the patient may have features of glucocorticoid insufficiency and mineralocorticoid insufficiency and androgen insufficiency. The patient have features like the most often presented with hypertension, altered mental status, and anorexia, vomiting, weight loss, fatigue, and abdominal pain. And reproductive complaints are typically present in women. The features like amenorrhea, loss of libido, decreased axillary and pubic hair. And patients have mineralocorticoid, decreased mineralocorticoid function. The patients have features of salt craving and orthostatic hypotension.
There are three features. Some features of cortisol deficiency, features of sex steroid deficiency, features of mineralocorticoid deficiency. Because it is primary. In the secondary, we don't have the other two, only we have the cortisol. This table also is from Harrison, just like the other two charts. Okay.
Coming to signs and symptoms of adrenal insufficiency. The first one, it is a glucocorticoid deficiency. The patient have features of fatigue, lack of energy, weight loss, anorexia, myalgia, arthralgia, fever, and patient have anemia, that is normochromic anemia, lymphocytosis, and eosinophilia. And patient have there is increased TSH levels, and patient have hypoglycemia, hypotension, and postural hypotension, and hyponatremia features. These are the features of glucocorticoid. And the features of mineralocorticoid deficiency, it is recurrent abdominal pain, nausea, vomiting, and postural hypotension, dizziness, salt craving, and increased serum creatinine due to volume depletion, and electrolyte disturbances like hyponatremia and hyperkalemia. And the symptoms of adrenal androgen deficiency, it is lack of energy, dry and itchy hair, and loss of libido, and loss of secondary sexual characters like axillary and pubic hair. And other signs or symptoms like in primary adrenal insufficiency, there is an increased ACTH. The patient have a hyperpigmentation of the skin. In secondary and tertiary, in secondary adrenal insufficiency, there is decreased ACTH. The patient have alabaster colored pale skin.
The point, one thing I have, one patient I used to have, he had a very dark palms. All of us, you see, the palms are comparatively lighter than the dorsum of the hand. If you see a patient where the palms are almost very black, particularly the creases of the palms are much darker than the rest of the palm, then you should suspect adrenal. What are the guiding features? Low blood pressure, postural hypotension, hypoglycemia, and then general weakness and lethargy are the features of primary disease. When it is, glucocorticoid deficiency, like that, in the primary mineralocorticoid deficiency also will be there in the primary. Then you have salt craving, low blood pressure, hyperkalemia. Hyperkalemia is due to the mineralocorticoid. Hyponatremia is due to loss of the feedback inhibition of the arginine vasopressin. If you have hyperkalemia, you can suspect, yeah, this person has got also mineralocorticoid deficiency. Sex steroid deficiency, lack of energy, itchy skin, loss of libido, and then secondary sexual characters are disturbed. And pigmentation of the skin is a feature of pro-opiomelanocortin, POMC, derived peptides are there. They induce what is called the pigmentation. We have had a patient who was around 40 years. He presented with very dark palms. That was not his complaint. He came for something else, and then he was getting recurrent giddiness, and then we saw he got postural hypotension, looked at the electrolytes, there is hyponatremia, there is a hyperkalemia, suspected adrenal. When we looked at the palms are very black as the dorsum, and the creases are very, very dark in color. So it fixed into primary adrenal disorder. Then we went into the disease. There was a deposit in the metastatic deposit in the adrenal gland, which resulted in the deficiency there in that particular patient. Okay, go.
And coming to evaluation of adrenal insufficiency, the most common features, it is hyponatremia with a hyperkalemia and a hypoglycemia. And we do lab assessments like serum cortisol, ACTH, renin, aldosterone, and chemistry routine investigations like CBC, serum electrolytes should be obtained. The initial testing in primary adrenal insufficiency should be measured autoantibodies like anti-21 hydroxylase antibodies, and these are responsible for destruction of adrenal cortex.
The commonest cause is primary adrenal insufficiency is autoimmune. So autoimmune destruction is through anti-21 hydroxylase antibody. So you measure that as the first step. And if that is not there, most likely it is not autoimmune. Then you measure cortisol. Cortisol should be low. ACTH also is low, means it is secondary. ACTH is reflexively very high due to feedback activation, and cortisol is low. ACTH is stimulated, that means you are dealing with primary. You do the renin and aldosterone to see the mineralocorticoid loop, and also do the chemistry panel. Most important are electrolyte abnormalities. Any patient with hyponatremia, associated hyperkalemia and hypoglycemia, and hypotension, and then dehydration, you should think of adrenal disease.
And we do infection panel for rule out of infectious diseases like HIV and tuberculosis. And adrenal insufficiency due to tuberculosis is more common in patients belonging to developing countries. The most common laboratory findings in chronic primary adrenal insufficiency are anemia, hyponatremia, and hyperkalemia. And these are the features of primary. And the patient with secondary adrenal insufficiency, the patients more have hypoglycemia, but these patients doesn't have dehydration, hyperkalemia, or skin hyperpigmentation.
Yeah, so that is how it is distinguished. They don't have the mineralocorticoid features like hyperkalemia, not much of dehydration, skin pigmentation also will be absent, hypoglycemia, weakness, hypotension will be the presenting feature. Whenever you are thinking of in the blood picture, there will be chronic disease anemia, that is normocytic normochromic anemia will be there. Okay. Now, this is a very important chart again from Harrison. So we will just try to focus on that, and I will try to enlarge. Okay. Go ahead with step by step.
And if any patient present to OPD with the symptoms of adrenal insufficiency like weight loss, fatigue, postural hypotension, or hyperpigmentation, or electrolyte imbalance like hyponatremia and hyperkalemia, so first we screen the patient. First we send the routine investigations like CBC to look for normocytic normochromic anemia, and look for serum electrolytes for hyponatremia and hyperkalemia, and creatinine. It is in adrenal insufficiency, there is volume depletion, so the raised serum creatinine and urea present. Any other associated immune disorders, so we rule out hypothyroidism. And next we send cosintropin test, that is ACTH stimulation test. And so in this test, we give 250 micrograms of ACTH, either IM or IV route, after giving 30 to 60 minutes after giving ACTH. So we measure cortisol levels. In this, it is less than 450 to 500 nanomoles per liter. So we confirm a patient have adrenal insufficiency. Next, we rule out it is primary or secondary adrenal insufficiency. For that, we send plasma ACTH, plasma renin, and serum aldosterone levels. If patient have high ACTH, high renin, and low aldosterone, so we call it as primary adrenal insufficiency. In primary adrenal insufficiency, the patient have both glucocorticoid and mineralocorticoid deficiency. So we replace both glucocorticoids and mineralocorticoids. In primary adrenal insufficiency, there are so many causes. So first we rule out there is any autoimmune dysfunction or any infective cause or any adrenal mass. So first we send adrenal autoantibodies. If adrenal autoantibodies are positive, it is most common, it is autoimmune adrenalitis. So next, we rule out other causes. So we send chest X-ray to rule out tuberculous adrenalitis, and the serum 17 hydroxyprogesterone. So if it is increased, so we, in children, so we label it as a congenital adrenal hyperplasia, and adrenal CT for any infiltrations, any tumors. And next one, it is we look for a plasma in men. We look for a plasma very long chain fatty acids. If it is increased, so we call it as adrenal leukodystrophy. So these are the causes of primary adrenal insufficiency. On other hand, there is secondary adrenal insufficiency. In secondary adrenal insufficiency, if the lab parameters, it shows low to normal ACTH and normal renin and normal cortisol. So we call so because of low ACTH, so we call it as a secondary adrenal insufficiency. In secondary adrenal insufficiency, there is only glucocorticoid deficient, so we replace glucocorticoids only. So we rule out secondary. We advise MRI pituitary. If it is a positive, if any lesion in any tumor or lesion, so it shows a hypothalamic and pituitary mass lesion. If it is there is no lesion in MRI pituitary also, so we consider the patient have taken from exogenous glucocorticoid treatment.
Yeah, history of adrenal trauma and consider isolated
ACTH deficiency.
Very simple. First of all, you should have a clinical suspicion on all the endocrine diseases, particularly the adrenal disorder. You have to, the index of suspicion, you have to keep it very high. Then only you will be able to diagnose in the early stages. Like in any patient will come, I'm feeling very weak, sir, I am tired, and you do you don't take record partial hypotension, you will miss it. Or if you don't look at the hyponatremia, you will miss it. So anybody presenting with, pigmentation, hyponatremia, hypotension, postal hypotension, fatigue, weight loss, dehydration, the possibility of adrenal insufficiency can be thought of. How do I go about? Do some routine blood tests, CBC, electrolytes, particularly potassium and sodium, look at creatinine and urea and other associated endocrine abnormalities, particularly TSH. Then you have got an ACTH stimulation test. Cosintropin is nothing but a synthetic ACTH. Synthetic ACTH is available as cosintropin. You give 250 micrograms of ACTH and measure the plasma cortisol around half an hour to 1 hour later. How this is given? This is given either IM or IV. If you give IV, you measure after 30 minutes. If you give IM, you measure after 60 minutes. That is the difference. Cortisol post-cosintropin should, if it is less than 450 to 500, that means in spite of giving an exogenous steroid, ACTH stimulation, the gland has not responded. Then there is some adrenal insufficiency going on. Then how do you differentiate? Primary adrenal disorder, secondary pituitary disorder. Primary disorder means both mineral and glucose are affected. That is why we will have reflex feedback stimulation of ACTH. ACTH will be very high, higher renin will be there, and there will be low aldosterone. Higher renin due to feedback stimulation of the renin axis by the mineralocorticoid, high ACTH due to feedback stimulation by low cortisol, high ACTH, higher renin, low aldosterone. With the above features is primary adrenal insufficiency. The other way around. Secondary adrenal insufficiency, ACTH is normal or low because the pituitary is not secreting, gland is all right, the adrenal gland, so low ACTH will be there. Mineralocorticoid is not affected by the secondary, so renin has got no business to change, aldosterone levels are not. This is basically, you separate primary from the secondary. In the primary, you require to replace both glucocorticoids and the mineralocorticoids because there is a deficiency in both. And you measure autoantibodies. Autoantibodies are positive, it is autoimmune adrenalitis or polyglandular syndrome, APS1 or APS2. If it is autoimmune antibodies are negative, of course you do exclude chest X-ray for tuberculosis and 17 OHP for the congenital adrenal hyperplasia, and then do the very long chain fatty acids in men for a specific condition, which is that VLCFA. And then you do an adrenal CT to rule out any infiltrations and mass lesions in this one. So these are the CT or X-ray or these are positive, that you are dealing with adrenal infection, infiltration, fecal lymphoma or hemorrhage or congenital adrenal hyperplasia, wherein 17-OHP is increased. If it is negative, the investigations are negative, it is autoimmune adrenalitis, most likely diagnosis. In men, you have to consider the leukodystrophy, wherein the long chain fatty acids will be increased. Come to the secondary adrenal insufficiency. The features are same features. Patient will present with weight loss, fatigue, personal hypotension, pigmentation may not be a problem. Hyponatremia will be there. Hyperkalemia will not be there. No pigmentation, no hyperkalemia. Such a patient, if you find out the ACTH levels are low normal or low, and then give the do the renin is also normal, aldosterone is normal. That means the axis of renin and aldosterone is not involved because it is higher in the pituitary level. There is only ACTH, that the replacement we require is only glucocorticoid, and we have to pin down the diagnosis of the pituitary. For that we do a pituitary MRI. The MRI is positive, it is pituitary mass lesion or hypothalamic mass lesion. If it is negative, the most common condition, exogenous glucocorticoid treatment could be the reason, or there could be head trauma. There is a condition we know, the adrenal insufficiency of head trauma. We have got and consider isolated ACTH deficiency due to a genetic defect. These are the various algorithmic evaluation of the patient. Now come to treatment.
Coming to treatment, in chronic, for treatment of chronic primary adrenal insufficiency, so we replace both glucocorticoids, mineralocorticoids or androgens. First is a glucocorticoid replacement. Either we give hydrocortisone, prednisone or dexamethasone orally. For hydrocortisone, the dose is 15 to 25 mg orally in 2 or 3 divided doses. The highest dose given in morning, that is 10 mg in the morning and 5 mg in the afternoon and 2.5 mg in the evening dose. That is 2 to 3 divided doses is given. And next are any prednisone 5 mg orally at bedtime, or dexamethasone 0.75 mg orally at bedtime.
Now the point here is we have to replace the glucocorticoids. I have got 3 options. I can give a fast-acting one, soluble hydrocortisone, or I can use prednisolone, which is intermediary in its action, and dexamethasone, which can be given once a day. So you have got an option of giving glucocorticoids more frequently in 2 or 3 divided doses, hydrocortisone, or give prednisolone orally at bedtime, and dexamethasone also can be given at bedtime. And in addition, I have to replace mineralocorticoid also, because in primary we have both mineralocorticoid deficiency and glucocorticoid deficiency.
And second is mineralocorticoid replacement. Normally we give fludrocortisone, like the dose is 0.05 0.5 to 0.2 mg. The mostly used dose is 0.1 mg orally. And along with, we monitor supine and standing blood pressure levels, and as well as pulse, edema, serum potassium, and plasma membrane activity. And last one is androgen replacement, like dihydroepiandrosterone. Initially, we give start with the 25 to 50 milligrams orally.
We are replacing the steroid, sex steroids also by DHEA, but more importantly, the mineralocorticoid replacement is a little tricky one, because patient can go into edema, patient can go into hypervolemic state. So what you have to do is start with 0.1 mg of fludrocortisone, available as Fludrocort, and 0.1 mg tablets are available. You give daily orally and keep monitoring the postural hypotension as well as the edema. You have to look at the serum potassium and look at the plasma renin activity, because you should not suppress the renin activity too much. At the same time, you must keep a balance. So it's a little tricky to give the mineralocorticoid, and you have to follow the schedule that is given here.
And it is the patient already known case of adrenal insufficiency, but patient undergone any stress or any patient undergo any surgery, so we replace the double the dose of actual glucocorticoid dose. So the glucocorticoid supplement for surgical stress, it is minor or major, or there is separate dosage. In minor surgery, we replace with the hydrocortisone 25 mg intravenous on the day of the procedure. In moderate case, we give hydrocortisone 50 to 75 milligrams intravenous on day of surgery and POD1. And in major surgeries, so we replace with a hydrocortisone 100 to 150 milligrams intravenous in 2 or 3 divided doses on the day of surgery, and continue with after POD1 and 2.
The principle of treatment here is steroid is a hormone required during stress. What are the stresses? Maybe febrile illness, maybe any other stress, maybe an operation, maybe a major surgery. Depending on the stress, you need to give the steroid. For minor things, you give a lower dose. Moderate, you give 50 to 75, and major, you give 100 to 150 milligrams, 2 to 3 divided doses. The idea is we want to overcome the stress, because there is a deficiency of cortisol, and cortisol is a stress hormone. It is a stress burst. Whenever we have stress, cortisol is secreted, and that takes care of the stress. And then that is why we require to cover the periods of stress, like surgery or anything, in the dosages that are prescribed here. The principle of treatment is we replace the stress hormone when the patient is stressed.
And next, and the last one is the complications of adrenal insufficiency. The patient there is no diagnosed adrenal insufficiency. He have undergo any stress or any illness. They may, this adrenal insufficiency they may precipitate into adrenal crisis. If left untreated, adrenal crisis can result in death. The patient may have a features of hypoglycemia attacks. These also precipitate the adrenal insufficiency. So they may land up in adrenal crisis.
Self-explanatory.
And these are the clinical and laboratory findings of adrenal crisis. The most common, the patient may presented with recurrent abdominal pain, nausea, and vomiting, along with the patient to have dehydration, hypotension, or shock out of proportion to the severity of current illness. The patient have hypoglycemia and fever, it is unexplained. And other features like hyponatremia, hyperkalemia, azotemia, hypercalcemia, or eosinophilia, and pigmentation abnormalities. And these are associated with other autoimmune endocrine insufficiency like hypothyroidism.
Pigment abnormality. One thing you remember, eosinophilia. So whenever there is deficiency of the steroid, you'll have eosinophilia. Okay. So in treatment also, somebody has got a very tropical pulmonary eosinophilia syndrome. Not only we give them the dicarbamazine, we also give them steroid to reduce the adrenal crisis.
Coming to adrenal crisis treatment, first we stabilize the patient. So for stabilization, we advise intravenous access with 1 or 2 large bore needles Infusion of 2 to 3 liters of isotonic saline or 5% dextrose in isotonic saline as urgently as possible. And we do periodic hemodynamic monitoring and measurement of serum electrolytes. Initially, we give hydrocortisone 100 milligrams intravenous bolus and followed by 50 milligrams intravenous every 6th hourly or 200 milligrams continuous infusion for 24 hours. Correct any ongoing after abnormalities, and hyponatremia is often corrected by cortisol and volume repletion.
The point here is adrenal crisis is a dangerous condition. What is the treatment? Treatment is replacement of fluid. What sort of fluid? Isotonic saline or deficiency. And then add along with it the cortisol. Hydrocortisone should be the choice because you should not give dexamethasone or methylprednisolone or something like that because they are not very quick acting. You have to give fast acting hydrocortisone. You have to give, and of course monitor the electrolytes and correct the hyponatremia. Depending on the hyponatremia, you infuse the quantity of isotonic saline. Okay.
Next, after stabilization of the patient, so we do intravenous isotonic saline. We continue with the intravenous isotonic saline infusion at slower rate for the next 24 to 48 hours. And we diagnose and treatment of the possible infection that may land up in adrenal crisis. And the tapering, next we do the tapering of the parental glucocorticoid over 1 to 3 days to the oral glucocorticoid maintenance dose. Last we do is initiating mineralocorticoid replacement with the fludrocortisone, that is 0.1 mg orally after stopping the saline infusion.
The point here is, whenever there is a adrenal crisis, your job is not to treat the mineralocorticoid, treat with saline and treat the correct dehydration, maintain the normonatremia, and don't give the mineralocorticoid to start with. Once the glucocorticoid is tapered, treatment is being stabilized, then you can supplement the mineralocorticoid. That is the point here. So, thank you, slide. Very good. Now I want to show you a few more things. Okay. So you see here, there are certain genetic abnormalities associated with congenital adrenal hyperthesia. 21 hydroxylase deficiency, 11 beta hydroxylase deficiency, 27 alpha hydroxylase deficiency, 3 beta hydroxysteroid dehydrogenase deficiency. We have seen where these enzymes act. Last time I have shown you that chart. So that way, this is very useful to remember what are the various deficiencies, what are the markers. Look at that chart, in Harrison, the variants of this one. This you have already shown. And this is the pigmentation. You can see the pigmentation of the creases and also see the pigmentation of the nipples and axillary areas also very much, and palatal pigmentation also can occur. The dorsum of the foot, you can see the pigmented patches here, hyperpigmented patches. This is in a very fair man, but in Indians you see a very different picture. The form looks as though he has put some ink or something, or some sort of messy onto the hand. If you put your hand in a messy and then wipe it off, then how it looks like? It will be like that. Messy pattinattuga, messy paarinattuga untai. Okay. Now you have this tables here, both of them you have shown. This also you have shown, and this is not related to this topic. This is another topic. So adrenal insufficiency starts here, and now I have got a slide page to show you from Davidson. Okay, so this is Cushing syndrome evaluation. Last time we discussed Davidson is much more clearer in how you go about that. You read the Davidson table of Cushing's evaluation, and then adrenal insufficiency beautifully here summarized here. So secondary decrease in the ACTH, we know, withdrawal or suppressive glucocorticoid therapy, and then hypothalamic or pituitary disease. He has combined secondary and tertiary together. Primary, we know the adrenal causes, autoimmune, sporadic, polyglandular, tuberculosis, HIV, AIDS, metastatic cancer, bilateral adrenalectomy, corticosteroid biosynthesis enzymes, congenital adrenal hyperplasia, drugs here given. Rare causes lymphoma, intraabdominal hemorrhage, intraadrenal hemorrhage, Waterhouse Friderichsen syndrome, meningococcal sepsis, amyloidosis, infiltration, hemochromatosis, under infiltration. Advice to the patient for glucocorticoid replacement, we have just now said, and they must have a steroid card. So we have to give them a bracelet saying that these people are adrenal deficient. And any emergency, they see the bracelet and start giving immediately fluids and hydrocortisone. So this should be a very important thing. And patients sometimes may present with vomiting, a prolonged vomiting. Parenteral hydrocortisone is useful in people who have prolonged vomiting. This is a very important table. So withdrawal of exogenous glucocorticoid is the fundamental common cause. There is a glucocorticoid deficiency, mineral is not affected, ACTH is excess is not there, adrenal androgen insufficiency is not there. This is hypopituitarism, which is the secondary. First one is the primary, tertiary, secondary. Then you have glucocorticoid alone, mineralocorticoid is not affected. There is no ACTH, but adrenal androgen insufficiency may be there if it is hypopituitary. When it is Addison's disease, that is primary adrenal disorder. Glucose is affected, mineral is affected, ACTH is excess in a feedback way. Renin also is in excess, adrenal androgen deficiency. Also is there hyperkalemia also. Congenital bilateral adrenal hyperplasia, which is an enzyme defect, 21 hydroxylase deficiency. That is the first one to be excluded, particularly in children. They have all the three, but adrenal androgen deficiency we don't see because it is a 21 hydroxylase is not involved in the androgen production. Clinical features also weight loss, anorexia, malaise, weakness, nausea, vomiting, diarrhea, constipation, postal hypertension, shock, hypoglycemia, hyponatremia, hypercalcemia. Whereas mineralocorticoid, hypotension, shock, hyponatremia, depletional hyponatremia, and hyperkalemia. Why depletional? There is no mineralocorticoid, kidney is not able to conserve, it's being excreted, it's being depleted. Whereas here, it is hypervolemia, which is causing dilutional hyponatremia. Whereas here, it is the depletional hyponatremia. And potassium is retained, potassium is not excreted, so there is hyperkalemia. There will be ACTH excess, can lead to sun-exposed areas, can produce pressure areas, can palmar creases. They can produce hyperpigmentation because the melanocortin-like peptides will be there. Mucous membranes may be involved, conjunctiva may be involved. If they have any recent scars, they also start becoming hyperpigmented. And adrenal insufficiency features will be the androgen insufficiency features are body hair distribution changes, loss of libido, especially is evident in the females. Okay, how to do ACTH stimulation test also, they have treat Davidson also. It is very nice to look at. This is what you have presented. This is the journal article. I hope all of you will read the journal article. And she has more or less brought out all the important features that are there in the journal article. I like this article very much because it is a very summary article. I don't know how Tejaswini felt about reading this article.